Hi there, thank you for listening. My name's Kath White. I'm a physiotherapist and the team leader at the Barbara Walker Centre for Pain Management, which is a specialist pain management service based at St Vincent's Hospital, Melbourne, and we provide a statewide outpatient multidisciplinary care. So my literature review is my top 5 papers related to clinical informatics and digital health and the outpatient waiting list management. In particular, I've chosen this because specialist clinics often receive referrals far in excess of their resource capacity. So, for example, at the Barbara Walker, we receive approximately 800 referrals a year, and we have capacity to only see approximately 300 patients a year. So, following a triage process, the wait time for urgent patients might be usually between 4 to 6 weeks, whereas if patients are triaged as routine on the waiting list, they wait 2 to 3 years before they are seen. It's obviously a huge task to appropriately prioritise referrals, and there are significant issues in ensuring that the multiple clinicians that take place in this triage are delivering quality decisions, consistent triage decisions that align with the evidence base, and that we are selecting the right patients and directing them to the appropriate level of service in the best possible time frame. And I guess my question, having completed much of the content of this subject now, is whether or not, in particular, could clinical decision support system assist with the management of these specialist clinic referrals. So to further investigate this, I searched both PubMed and the CINAHL database, looking for papers from 2015 to 2017. I used a mesh term search, combining various terms such as clinical decision support, outpatients, triage, waiting list, and electronic health record. I had considerably more success in PubMed than CINAHL. However, within the time frame, there was nothing specifically that related to waiting list management in specialist clinics, and therefore I needed to take a broader approach to clinical decision support learnings and to look to extrapolate some of these learnings to the specialist clinic setting. There were 47 publications that I identified as being broadly related to clinical decision support and potentially of relevance to the management of specialist clinics. So in looking at the 47 potential studies, I reduced the number of studies that I was looking at further by excluding the settings or studies that I didn't think were particularly analogous to the outpatient waiting list scenario. This meant, in particular, I actually excluded studies which looked only at emergency department triage. And that's because although they did routinely use clinical decision support systems, the primary purpose of those clinical decision support designs was often around issues such as rapid patient flow and the timeliness of access to emergency care for patients triaged as urgent category. And I felt that this was of less relevance to the outpatient waiting list scenario, where we were actually really just looking at adherence to evidence-based guidelines and the intra and inter-reliability of various clinicians on making those decisions. In selecting my top 5 papers, the key rationale that I used was I was essentially seeking information that was going to guide the development of a clinical decision support tool at our specialist outpatient service. Given that we have moved to an electronic health record, I was also particularly interested in a clinical decision support system that was integrated within the electronic health record. I selected research designs that were as strong as possible. So systematic or integrative reviews, followed by RCTs or observational studies. I then chose papers that I felt related to a similar field of practice. I've already mentioned excluding the emergency department triage scenario. So looking at similar fields of practice or the type of clinical decision being made. So clinical decision support systems that were also designed to maximise adherence to fairly simple guidelines or evidence-based protocol. Those that generated alerts if a decision was not aligned with the evidence base. Clinical decision support tools that could be utilised by a multidisciplinary team. Ones that were integrated within the electronic health record. And I was particularly interested, I guess, in this because one of the areas that we've fallen down with our own triage is the documentation of this process. So looking to have the transparency of decision making also improved. And essentially I chose the papers for practical key learnings which would inform the implementation of this tool when managing the outpatient waiting list at my workplace. So in actual fact, having applied that rationale as to how I selected the most interesting top 5 articles, my first article is not one that is specific to clinical informatics or digital health. In fact, it was a systematic review published looking at what exactly is orthopedic triage. And they were looking to investigate the nature of these outpatient triage clinics. In this scenario, looking at chronic orthopedic conditions. So it was quite a large systematic review. The search and methodology was sound. They used the McMaster Quality Appraisal Tool and the NHMRC hierarchy guidelines to establish the quality of the 45 studies that they ultimately identified as being relevant after a well-described search strategy. The level of evidence was, generally speaking, low. Level 1 and Level 2 studies only, 1 in each, 12 Level 3, 29 Level 4, and in fact one study that they felt was unable to be scored. And it did provide some key information about these type of workforce reforms and service developments which have essentially aimed to provide timely appointments, direct patients towards optimal care, and streamline the valuable medical consultant time and minimise time wasted waiting for care on these huge outpatient waiting lists. The key themes that they identified was that the key purpose of triage was to address the extensive wait times for specialty services through a streamlined screening process. And the other themes investigated included the configuration of these triage clinics, who was delivering the triage, how are they doing it, and where. I've already mentioned that in relation to our service, the WHO is a multidisciplinary team, and that wasn't out of step with the findings of this systematic review, although several of the studies did look at an advanced practice substitution model whereby an advanced practitioner, often a physiotherapist, was being evaluated for the quality of their triage as compared to the gold standard medical consultant triage outcome. So I guess in particular I was interested in the how of the triage. Were any of these studies using a digital clinical decision support system? Was there any integration into the electronic health record of the type of tools that we're envisaging for our service? And in fact, only 5 studies identified use of a standardised tool, which I found surprising, given the huge task at hand. Generally speaking, they identified They identify the expert skills of the triage clinician as negating the need for a standardised tool, which I thought was interesting. Of the 5 studies that reported using a standardised tool, 3 used these during a paper triage process, and the tool was also a paper-based tool, and 2 used them during direct clinical assessment, but again, the tool was a paper-based tool. So essentially, I've taken this as a starting point. It really provides some baseline knowledge, I think, to help answer the question as to what may be useful, what are the type of issues that are being addressed. It appears that even though outpatient waiting list management is a significant issue, there's a lack of consistent approach, and the approach is not necessarily evidence-based. Most interestingly, this systematic review did not identify the use of electronic clinical decision support systems in the management of outpatient waiting lists. So given the systematic review, which was looking at outpatient waiting list management, did not identify the use of electronic clinical decision support systems in any of the triage clinics, I now moved on to other research looking at clinical decision support systems in scenarios that I felt were analogous to the outpatient waiting list management. So, as we now know that clinical decision support systems are not currently being used for outpatient waiting list management, or that's what the literature seems to indicate, where are they actually being utilised and how? So, this first systematic review by Lopez et al., published in 2016, is an integrative review, so including both qualitative and quantitative studies looking at clinical decision support systems described in publications between 2006 and 2013. They had quite an extensive search looking at a variety of medical, allied health and engineering and IT databases. And ultimately, after excluding duplicates and applying a variety of exclusion rules, largely pertaining to the relevance of titles and abstracts, they retained 28 studies on which they assessed the hierarchy of evidence presented, and also looked at the quality of the study rigour. Although given the mixed study designs, that was particularly challenging, as it is with any integrative review. So from these 28 studies describing a variety of clinical decision support systems utilised primarily by nurses, also by advanced nurse practitioners and medical professionals, there were several key features that were identified with those that were termed to be successful. And success was described in a variety of ways, obviously depending on the objective of the tool. But in particular, the study authors looked at changes to patient outcomes or demonstrable changes to hospital processes or resource utilisation. So successful clinical decision support systems were aligned with workflow. They offered timely recommendations at the location of the decision. So, for example, if the nurses were making a decision in relation to medication, and that decision was usually made bedside after undertaking a series of OBS, that's where the recommendation would be made. And they were also integrated with the electronic health record. This was thought to be partially related to the fact that it's more efficient to be integrated with the electronic health record and saves on multiple logons, use of multiple systems, and largely a time-consuming model of utilising clinical decision support when it's not integrated. So the barriers to successful clinical decision support systems were poor administrative support, minimal time allowed for clinicians to learn and for successful implementation of the tool, and deficiencies with the integration with the electronic health record. As I mentioned, a requirement to utilise multiple logins, interruptions to access, so dropout of connectivity in some parts of the hospital or primary care environment, for example. So really the take-home message from these 28 studies looking at clinical decision support systems that both nurses and medical practitioners utilised was that alignment within the workflow and interoperability within the external electronic health record is a key factor in success. Moving on to the next article by Miller et al. I felt this was a really interesting addition to the recent knowledge base. It's actually a meta-synthesis of 9 qualitative studies, and their explicit aim was to investigate possible reasons for the mixed research results to date for clinical decision support systems, and they wanted to better understand some of the issues that might be contributing to these mixed outcome results by aggregating some high quality qualitative research findings. So their study design did follow a highly structured literature search, looking at publications in English peer-reviewed journals from 2000 to 2013, and they may have been clinical decision support systems utilised by physicians, nurses and advanced practitioners. There were initial 56 studies identified, and they evaluated them for methodological quality against the McMaster guidelines, gave them a score, and then they took the top 25% scores. So only further evaluated what they considered to be the top quartile of quality studies. They then used an inductive approach to generate key themes and allocate the findings from all the studies into a variety of thematic groups. In fact, and that was a 3-step process involving 4 different reviewers. I felt their methodology was sound. The 5 key themes which emerged as barriers to the utilisation of clinical decision support systems were the usability. So this included nuisance issues such as repeated alarms, or control issues such as the inability to override or turn off alarms when clinicians felt that they were inappropriate, or in fact the intelligibility of these alerts. So for example, using terminology or figures that were too technical, or perhaps at a pharmacist level of knowledge rather than a nursing clinician's level of knowledge. The clinician-patient system integration issues identified particularly highlight the importance of the clinical decision support system combining effectively with clinical judgment. Interestingly, they identified that where this congruence doesn't occur, and clinicians don't therefore trust in the clinical decision support system, that there were several examples where clinicians may in fact alter their data input in order to influence the outcome from the clinical decision support system. Clearly, such manipulation of a tool that's meant to assist in decision making is actually undermining of the purpose of these clinical decision support systems. So to me, that really highlighted that clinicians need to see the value in the clinical decision support system, and it needs to allow for some capacity for clinical judgment to also be involved in the decision making. The need for better algorithms was, I guess, in part aligned with this concept and was repeatedly identified by clinicians when they believed that the clinical decision support system wasn't able to accommodate the complexities of the real world, or simply not mature enough. For example, sounded like one fairly basic clinical decision support system couldn't accept the concept that an asthma patient might need 2 or more preventative medications, and therefore would trigger an alert when more than one had been prescribed, which clearly is not an algorithm that is aligned with the best practice recommendations for asthma management. The system immaturity and patient safety related to concerns around data security and broader platform interoperability, such again as multiple logins or regular systems crashes, insufficient support or design alterations being available. So the take-home message from this meta-synthesis was that without further understanding of the contextual issues around clinical design support, particularly in relation to usability or integration of these systems, quantitative research findings are likely to continue to be confounded. In particular, a better understanding of the interaction between the human and computational reasoning in the real world is required, including the adaptation of the clinicians over time. So going back to that example where nurses might change their data input in anticipation of the decision that would be delivered by the clinical decision support system, there's a need to better understand how clinicians might change their interaction over time. So moving on now from the larger reviews to a study that looked more specifically at one particular clinical decision support tool, and in fact a quite successful implementation of a clinical decision support tool within an electronic health record. So this was a large American observational study that took place in one of the largest healthcare services in America, in the Carolinas. So over 40 hospitals and 900 primary care locations. This particular service had over 11 million health encounters in 2013, and their average asthma-related emergency department visits were 6,378 per year for the 3 years leading up to 2013, and similarly 1,384 hospitalisations. They studied a tool that they'd embedded within the electronic health record to streamline the application of evidence-based guidelines for asthma management, in particular the creation of an individualised asthma management plan for patients, because a recent Cochrane review of 36 studies had in fact shown significant reductions in emergency presentations and hospitalisations for patients with individualised asthma action plans. However, despite this, and hospital guidelines and protocols indicating that individualised asthma management programs should be developed for all patients, a study previous to this had identified that in fact that was not happening in the case of many patients. Compliance had been limited and the barriers were detailed as lack of time, inexperience and insufficient confidence in generating an appropriate individual asthma action plan being cited as the core reasons. So the project embedded a tool within the electronic health record to streamline these very complex asthma guidelines, which I didn't realise were quite so complex, but apparently the American guidelines currently sit at around 440 pages long. So no wonder it was challenging for clinicians to create an individualised care plan for patients on the basis of such complex evidence base. It seemed to me they did a lot right with their implementation of this tool. They described a 4-phase implementation. Initially, a web-based prototype was developed, and this allowed for quick revisions based on feedback by a multidisciplinary team who were engaged to trial, pilot, feedback. The multidisciplinary team involved physicians, nurse practitioners, IT administrators, and quality specialists, and it was actually revised regularly during the study in order to ensure that the appropriate representation was there from key personnel. The multidisciplinary team met every 4 to 6 weeks over a year's lead-in period where they trialled the web-based prototype, gave feedback, and then looked at pilot testing at 5 different sites. And again, more changes were made to the tool before system-wide dissemination. At each point in the process, they emphasised that the key focus was that the tool had point-of-care convenience and it worked in easily with the provider's workflow, both issues that we know to be important from the Lopez et al. Review. The 5 pilot sites were piloted for approximately 6 months, so a decent duration. Changes were made, and then on the basis of services self-identifying as being likely to benefit from the tool, 100 primary care practices signed up and received individualised training from the team, and in addition to that, ongoing support and training videos. So that was the implementation phase. As patients were issued with the individualised asthma management plans, the electronically generated ones, they were assigned a matched control. These were based on a variety of criteria, and the authors report 97% agreement between participants and their controls. They were a diverse group in regards to race, gender and socioeconomic status. There were significantly more children than adults. The total participant number was 3,675 in receipt of the asthma action plans over the year's study period, and of these 2,783 were children, with the remaining 892 adults. So interestingly, result-wise, despite the incredibly high numbers, they reported that they didn't actually have sufficient power for examining changes to adult inpatient stays, because that's a relatively uncommon occurrence. However, for the adults, there was an improvement in those prescribed oral steroids in outpatients. So, and that was significant. More impressively, for children who received an individualised asthma action plan, they had 33% lower odds of requiring oral steroids in an outpatient visit. And you can see the confidence intervals there fairly strong. And exacerbations were 25% lower for those that received the electronic asthma action management plan. So they demonstrated significant changes to patient outcomes, particularly for the paediatric population. Clearly, a limitation of this study is the observational design. So they really only demonstrated association but not causality between the electronic asthma action plan and the reduction in outpatient steroid prescription, exacerbations, and inpatient stays for children. I think the key messages that I took away from this relating to clinical decision support is that the embedded design in the electronic health record worked very effectively and was well utilised by clinicians. However, there was a really extensive path to this successful implementation, and it was perhaps because of this that measurable patient outcomes were achieved. So, my final paper wasn't quite as impressive in terms of the outcomes it reported. It's an RCT that was evaluating the impact of alerts embedded into the electronic medical record, designed to improve the processes of triage at the emergency department. Now, I did say that I had excluded the majority of emergency department publications. And the reason why I've included this one is, while it is based in the emergency department and they discuss triage protocol, rather than some of the other studies which were looking at how patients were triaged and then the rapidity of their progress through the triage involvement in particular. This study is actually looking at how nurses then adhered to a specific protocol that related to the ordering of urine analysis and x-rays in a particular clinical case scenario. So not actually looking at triage decision making per se, but looking at how they adhered to a protocol which was evidence-based in the emergency triage environment, if that makes sense. So it was an RCT, which was one of the reasons why I selected it. But in particular, I'm interested in the concept of alerts when decisions are made outside the evidence-based guidelines. So this study looked at 28 nurses, and those nurses were randomised to either receive alerts or to receive no alerts for two types of medical complaint. Between them, the nurses saw approximately 20,000 patients in the 6 months prior to alert instigation and a very comparable number in the 6 months after instigation. Interestingly, adherence to protocol increased in both groups, both those nurses receiving the alerts in relation to ordering urinalysis and those not receiving alerts after the intervention had been implemented. So the study authors identified, and it's fairly clear, that this is in fact likely Hawthorne effect. So the nurses had been consented to participate in the study. So they knew that they were being studied. And as a consequence, there's a belief that their adherence to the protocol guidelines therefore improved, not as a consequence of the alerts, because they improved in both the non-alert and alert group. There was also suspected contamination between groups, whereby they suspect one of the nurses who was receiving alerts was placed on shifts with those who weren't receiving alerts and may have communicated the presence of these new alerts. So you can imagine a conversation along the lines of, oh, do you keep getting this in relation to urine analysis? And it was felt that this probably further played into the likely Hawthorne effect. So there wasn't really a lot to take away from this study in terms of how effective the alerts were and whether they improved adherence to the evidence-based protocol. I think the message I took home from this is it's actually really difficult to evaluate these types of tools, perhaps in particular for alerts which have been documented as being potentially considered irritating for clinicians. And so any design that looks to evaluate these type of tools is going to need to take into account the likely Hawthorne effect. So the authors suggested a potential ethics application which looked at waiving consent for participation, so the nurses not consenting necessarily to the study taking place, given that they would just continue with usual practice. Or needing to alter the study design, or looking at a multi-centre study, or perhaps I was thinking you could also do that between different outpatient clinics where there would be very low likelihood of cross-contamination between those who were receiving the intervention and those who weren't. Clearly, it's quite difficult to blind to an intervention, such as an alert popping up, as participants must be necessarily aware of this alert. So I think there's no doubt that there's plenty of questions for further research into this area. I guess first to touch on some of my predictions. This isn't a new area in terms of specialist outpatient demand has been documented to be enormous and significant for quite some time. It has been the receipt of quite substantial attention from various departments of health in terms of initiatives to improve waiting list times, and it does, I believe, lend itself to some form of electronic clinical decision support system to assist with the triaging process. Ideally integrated within the electronic health record as that becomes standard. I wonder whether given I think the obvious potential benefits of using clinical decision support system, that this is actually happening in practice in the real world. It just hasn't made it through to the literature as yet, and it would be interesting perhaps to look at some of the grey literature rather than that published in peer-reviewed journals. I also anticipate that with the increasing emergence of electronic referrals, ideally integrated within the electronic health record, looking at utilising standardised language aligned with SNOMED CT, for example, does have the potential to further assist with this clinical decision support, in particular looking to screen for red flags in a referral that might require urgent action. Clearly, we're not at that point yet, with many referrals still coming in via fax or paper-based. So I would suggest that the research needs to be carefully structured to avoid the identified likely issues of bias and cross-contamination in outpatient setting. But I do believe that there is potential to improve the outpatient triage process. I think the key questions are as to whether or not a clinical decision support system can improve both the inter and intra-rater reliability of triage decision making. So for any given clinician on a given day, does the clinical decision support help them to be more consistent with their decision making and perhaps less vulnerable to issues of implicit bias or stigma or stereotyping? Does it assist across the disciplines for the decision making to be comparable? So is a nurse likely to make a similar decision to the physiotherapist, to the specialist medical practitioner? And in particular, as I've mentioned, I think if clinical decision support systems could be shown to improve the identification of urgent referrals, that would be of tremendous benefit to patient outcomes. So finally, where to from here for an outpatient service such as mine that's looking to potentially improve its consistency and quality of triage decision making in relation to a very long outpatient waiting list? I guess the key messages that I took away from this is that triage of outpatient waiting lists is practiced throughout Australia, which we knew anyway, in particular for those very in high demand specialist services. But at this stage, there doesn't appear to be a standardised approach to this decision making, nor any utilisation of electronic clinical decision support systems. So it's an area ripe for development. A successful clinical decision support system in this area would need to align well with the workflow, integrate into the electronic health record, and have a very well-resourced implementation. That's probably a key learning for me. It's not a project for us to undertake lightly. Significant impact on patient outcomes have been demonstrated with similar tools. However, the research needs to be really well designed in order to evaluate this effectiveness, because there's likely to be a Hawthorne effect and cross-contamination if the study is not well designed. The value of an alert system is less clear and probably something to look out for in the literature in the future. So thanks very much for listening. I don't think there's been any clear answers in relation to my literature review. We will hopefully look to implement such a project at the Barbara Walker Centre, and I'm motivated following this literature review to ensure that we do it in a way that we might be able to add to the literature base out there. Thanks very much.